process. The advantage are good centration, stability, and improved visibility. Extremely useful in patients with advanced ectasias who are intolerant to contact lenses or when immediate surgery is not possible, but they are limited because of their high cost and the reduced tear exchange and difficult insertion and removal. It's a one-fit contact lens fitting. A small video clip.
So this is the right eye.
Yes, sir. Next comes the surgical management, where very varied options are available, like intracorneal ring segment inserts, collagen cross-linking, CXL, lenticular refractive surgery, corneal transplant. The brief account of each of those ICRs, or the intracorneal ring segments, Ferrara rings have a fixed inner diameter of 5 mm with a triangular anterior contour. Inner diameter of intacs will be 6.8 mm and a flat anterior contour with a hexagonal in cross section. The ring segment should be inserted up to 2/3 depth of the cornea, and minimal corneal thickness should be 450 microns, and they do not prevent the progression of the disease. The technique involves implantation of 1 or 2 PMMA segments in the stoma to flatten the central cornea. Intralamellar pockets are created with the help of a vacuum lamellar dissector or a femtosecond laser. Next modality is a collagen corneal cross-linking, the most recent addition to surgical management, which has been introduced since 2000. From 1998. It may slow or halt the progression with photooxidative treatment to increase the rigidity of the stoma. 60 to 70% of the patients show some stabilization following this treatment, whereas the therapeutic effects are limited up to 300 microns of the anterior stroma. And it should not be performed for corneas less than 250 or 300 microns. It carries a slight risk of development of keratitis. Under the topical anesthesia, 6 to 7 mm of central epithelium is removed and riboflavin 0.1% solution is added topically, which is a photosensitizer agent, for about 10 to 30 minutes, and cornea is irradiated with UVA light of 370 nanometer for 30 minutes. There will be different protocols like Dresden protocol, accelerated Dresden, Athens protocol, etc. And the production of reactive oxygen species helps to create covalent bonds between the collagen fibrils. The final treatment modalities of keratoplasty, which is penetrating keratoplasty or can be lamellar keratoplasty. The penetrating PK has success rate in 90 to 95%, and visual recovery takes several weeks to months, and full stabilization might even take a year. Eye drops that does not clear by 3 to 4 months is best treated by PK. And the other lamellar keratoplasty is the most common done is a DALK, that is deep anterior lamellar keratoplasty. It is a procedure of choice as there is a good endothelial count even after eye drops. The advantages of DALK or PK are there's reduced risk of rejection, reduced risk of end-off, greater wound stability, and reduced need for topical steroids, leading to faster healing. And it consists of layer-by-layer manual dissection, partial trephination of variable ranging from 50 to 70% of the cornea is removed. Stoma is removed with the help of a crescent, and layer-by-layer removal of the as close to the Descemet's membrane. But limitation can be poor visual outcome due to residual stoma. And the DAL can be air-assisted, can be femto-laser-assisted. In air-assisted DAL, the different techniques like big bubble technique, Anver's technique, where air injection is done into the stoma through a groove created by trephining 60 to 80% of the stromal thickness. And air infiltrates a potential space between the stoma and Descemet's membrane, create a dome-shaped detachment of Descemet's. Once a plane of separation is created, the stoma can be easily excised. And femto-laser-assisted DALK, it can be used to create corneal incisions with customized graft edges and lamellar planes. Advantage is accuracy of forming the bubble at the desired depth, positive refractive outcome, but the limitations being cost and availability. The second, which after keratoconus, which common we see is keratoglobus. It's a bilateral ectatic disorder, which is non-progressive, usually present at birth, or even can be minimally progressive. It will be generalized thinning of the cornea with marked peripheral thinning. Can be of two types, either congenital type, which is an acquired LL type. Congenital can be associated with Ehlers-Danlos type 4 in brittle cornea syndrome. Acquired LL type can be initially keratoconus going to keratoglobus. The clinical features being blurring of vision, corneal perforation can be spontaneous or following minimal trauma. Rarely might present as glare, pain, photophobia, conjunctival injection. They can be limbus to limbus corneal thinning and blue sclera due to thinning. It should be differentiated from keratoconus, PMD, megalocornea, and congenital glaucoma, where in megalocornea, the diameter of the cornea usually is more than 12 millimeters, whereas in congenital glaucoma, the intraocular pressure will be raised. There will be fundus features of disc cupping, which are not seen in keratoglobus. So how we do the diagnosis is essentially clinical. Ultrasonic pachymetry shows reduced corneal thickness, and corneal topo shows generalized thinning and irregular astigmatism. It's difficult to perform in advanced cases. How do you medically manage? It's a conservative. Observation is a rule in the early cases. A patient is advised to use glasses. Usually rehabilitation is done using refractive correction for high myopia. Like other contact lenses like scleral lens, RGP lenses, large diameter inverse geometry RGP lenses can be used. And surgical management is very difficult to manage the patients where large size grafts are used and they have the chance of increased risk of rejection. And peripheral sutures often cut through, and proximity of the graft to the limbus increases the risk of rejection and the higher chances of perforation. The other ectasia is a pellucid marginal degeneration. It is also a bilateral corneal ectatic disorder, where the name pellucid was chosen by Schleppi, which means clear. That is, it is free from lipid degeneration and free from vascularization. So the band of thinning is seen 1 to 2 millimeters inferior in diameter, extending from 4 to 8 o'clock clock hours. Area of thinning is separated from the limbus by 1 to 2 millimeters of the normal cornea. Usually it is a inferior thinning, and the cornea is seen protruding superior to the thinning, classically the beer belly appearance. Usually the onset is around 2nd to 5th decade of life. The presentation is with blurring of vision due to against the rule astigmatism, the frequent change of glasses, and the ocular examination reveals thinning of the inferior cornea, which separated one clear zone 1 to 2 mm from the limbus, and ectasia is just superior to thinning, and protruding cornea is of normal thickness. Occasionally, Dismut's folds are seen inferiorly. On the investigations on corneal topo, because of against the rule superiorly and with the rule inferiorly, classically the crab claw appearance, that is inferior peripheral steepening extending to mid periphery is a picture. So how do you manage? Again, spectacles in the early cases and contact lenses in the late stage. A large diameter PK, it can be done in two-step procedure where combined large diameter lamellar keratoplasty can be done in the first stage, followed by small diameter penetrative keratoplasty, or there can be crescentic lamellar keratoplasty, crescentic or wedge excision if ectasia is in small sector inferiorly. The other degeneration which has to be differentially diagnosed has to be the Terrien's marginal degeneration. Classically, it is seen the superior thinning with lipid deposition, seen middle-aged to elderly people, bilateral males, and vascularization crosses the area of thinning and perforation is unusual. And the other entity is the progressive keratoconus. It is a congenital corneal anomaly in which the posterior corneal surface protrudes into the stroma. It is a sporadic, unilateral, non-progressive. It can be a variant of corneal mesenchymal dysgenesis where the scarring is seen anterior to the descemal bulge. In the pathological examination, scarring is seen at the Bowman's membrane and thinning of descemal membrane with excrescences, usually with spectacles, or can be used to correct. In post-LASIK ectasia, where the Randleman et al. In 2008 defined the corneal ectasia post-LASIK as inferior topographic steepening of 5 diopters or more with immediate post-operative appearance, or loss of 2 or more lines of Snell lens visual acuity, change in manifest diffraction of 2 diopters or more of either sphere or cylinder. Where the incidence is now with the available studies, it is around 0.05% per year. And for every follow-up, the clinician should look for either increased myopia or increased cylinder, changes in keratometries but order of higher aberrations, decrease in pachymetry over time. Histopathologic studies suggest that interlamellar, interfibular biomechanical slippage occurs and cornea becomes ectatic after LASIK or PRK in the post-operative stress-bearing regions. So the management can be corneal cross-linking, intacs, and keratoplasty. The corneal cross-linking can be done combined with the PRK or even later. So to summarize, if you can see that most 3 common conditions, keratoconus, the pellucid marginal degeneration, keratoglobus. In keratoconus, both the area of thinning and protrusion coincide the same place. Whereas in pellucid, it is inferior thinning and superior protrusion over it. And keratoglobus is diffuse thinning. So to just compare, the keratoconus, the frequency is most common, PMD is less common, globus is rare, and posterior keratoconus is also least common. And keratoconus usually it is bilateral, PMD both all are bilateral, and posterior keratoconus usually unilateral. The age of onset is keratoconus at puberty, PMD around second 20 to 40 years of age, and keratoglobus and posterior keratoconus usually present at birth. And coming to thinning, it is inferior paracentral in conus, whereas in PMD, it is inferior band wide, and keratoglobus is greatest in the periphery, and posterior keratocone is paracentral and posterior. The protrusion of the cornea in keratoconus is thinnest at the apex, whereas in PMD it is superior to band of thinning, and keratoglobus is generalized, and there is nothing in conus. The iron lines, lesions, ring, and scarring and striae are common in conus. And PMD, the iron line is sometimes seen. Scarring can occur after high drops, and sometimes striae can be seen, whereas in globus, they're little mild, and in posterior conus, sometimes they can see in scarring. So take-home message is follow-up evaluation. Progression is to be carefully monitored, and the patient should be very compliant to the frequent follow-up and prevent the loss of visual function. Thank you.
Thank you, Dr. Madhuri, for that very exhaustive talk. I think you've covered all the dimensions of corneal ectasias extremely well. The panelists, would you like to ask any questions or any queries? They're most welcome. Otherwise, I have a few questions in the chat box. So just to quickly recapitulate, Dr. Madhuri, what are the indications for collagen cross-linkage in a case of keratoconus? When do you think this patient needs to be taken up, and which are the patients that need to be followed up?
Usually, steep K, more than 45 diopters, K patient presenting in age group in the teenage in the first attempt, and even patients have any clinical signs of VKC or frequent eye rubbing. And if the patient is already the high cylinder, if the family history of keratoconus in their family. And depending on
which are the patients? Yeah, which are the patients that need to be taken up for like an immediate collagen cross-linkage, and which are the patients that you can follow up, and then decide later? So what is the criteria?
Usually here we follow any patient in the teen age, like between 13 and 15 or 16 years, and with more than 3 or 4 cylinders, we usually take for CXL, ma'am. If it is, their patients are above, more than 18 or more than 20 years with stable our frequent follow-ups, which then we can observe. And more than
Thank you.
Also we are taking for CXL.
Also, what are the indications for DALC, and what are the indications for a penetrating keratoplasty? How do you decide when to take up a patient for which surgery?
We usually take depending on the corneal topo. If there is a central scarring, and if the scar is more like anterior, you say around below 400 microns, if the scar is like that, then we go for DALC. If there's more steep K and scar is more deep, like you say more in the posterior stroma around 250 or below 200, we go for PK if the good corneal tissue is available. And depending on the age and the patient's compliance, depending on the other eye status also, we'll decide whether it's good for DALC or PK. Usually we are going for DALC. It's giving good results compared to PK in our scenario.
And does the keratoconus recur in patients in whom you've done PK? Is there a tendency for that again to recur? Because we know it's a genetic disease and that can also happen again.
Like
so eye rubbing and all has to be told to the patient.
Yes, that is a thing. Yes, like out of 10 cases which we are following up for the past 5 to 6 years, 1 case has got recurrence.
And also, how do you decide when to do intacts for a particular patient? If you could just elaborate on that. Intacts or cares or any of these procedures.
We are not doing intacts in the center. I don't have much experience. But you have to say that, like, there is no scar.
So if there's a patient of keratoconus who comes to you today, would you like to give him a contact lens, a rigid lens, spectacle correction, or advise him corneal cross-linkage? Like, how do you decide what is the modality that you have to, to visually rehabilitate him?
First, we give us if the patient is coming directly to us without any prior spectacle use, first we give first spectacle correction first. And depending on how he is using, if he has no rubbing, if we feel clinically and on topo every 3 months, if it is being stable, then we give the option of contact lens. And we are going, we are doing, RGP has become out of date. We are giving the 1-fit lens, which is still lens, which is really doing good. And if we
Which lens is this? Which lens?
1 fit scleral contact lens.
Okay.
So if the patient is not so compliant and which we feel he's habitual rubbing and we can see other symptoms, first we stabilize the surface and then we go for CXL. First is a spectacle correction. Then only after 3 or 4 months, which we feel is stable, then only we are giving a contact lens correction.
Thank you.
Thank you.
So any of the panelists are most welcome to join in and comment in case there are any comments. Otherwise, we'll move on to the next talk. Okay. So our next speaker is Dr. Partho Pratham Datta Majumdar. Dr. Partho Pratham is an alumnus of the Silchar Medical College and fellowship trained in medical retina and uvea at the Shankar Nethralaya. He currently holds the position of senior consultant in the uvea department in Shankar Nethralaya, and he's had a very illustrious career so far. A prolific writer with multiple national and international publications to his credit, he has also won numerous accolades and held various editorial positions. He is also the founder cum chief editor of the very popular ophthalmology portal www.eophtha.com, and I'm sure a lot of the postgraduates have logged on to that portal. If not, please go and visit it. It has very useful nuggets of information for all the PGs. So, Dr. Partho Pratham, I welcome you all. I welcome you today. And Dr. Partho Pratham would be speaking to us on the basics of uveitis. So, over to you and looking forward to your talk.
Am I audible?
Yes, we can hear you.
So thanks, Dr. Tinku, for the kind introduction. So good evening, everyone. I thank our President, Dr. Harvansh Lal, and Dr. Santosh Honavar, the General Secretary, and the entire team of AIOS for this innovative session, GuruSangam. I hope this series of videos will be highly beneficial for the students. So I'll be talking on very basics of uveitis. So just to make this complex topic simple, I have drawn a series of diagrams which I'll be using throughout this presentation. So immune privilege is thought to reflect an evolutionary adaptation to protect the vital structures from the damage by the inflammatory responses directed against any pathogens or any body structures. So the plan of the nature is to conceal the antigens or in such organs of the immune system by physical barriers. Other than the eye, what are the organs that have such privilege in mammals? It is the pregnant uterus, it is the brain. So these are the organs which the body or the nature wants to prevent from any kind of immune reaction or immune damage to secondary to the response. Now, when we look at the eye, there are two big check gates within the eye, which regulates the movement of the substances between the bloodstream and the eye. So these check gates, they selectively allow certain substances to pass through while blocking the rest of the products. So this ensures that only the necessary nutrients or fluids will enter the eye and maintain its clarity and composition. So sometimes because of these barriers, many of the drugs which we administer systemically cannot enter the eye, or even if they do enter, they do so in very limited quantities. So the first barrier is the blood-aqueous barrier, which consists of two main components, the blood-iris barrier. The blood-iris barrier is formed by the endothelium of the iris blood vessels, and this next one is the blood ciliary body barrier, which is formed by the ciliary bodies, specifically the non-pigmented epithelium of the ciliary process. So this barrier is responsible for the secretion of the aqueous humor and has tight junctions that control the exchange of the substances. Now, this barrier, the first barrier, is essential for maintaining the correct composition of the aqueous humor, and it is essential for preserving the optical properties and health of the eye. So you understand that how it plays a critical role in protecting the eye from the blood-borne substances and pathogens that could come and cause the inflammation of the eye. The second check gate is to regulate and restrict the movement of the substances between the bloodstream and the retinal tissue. So this blood-retinal barrier consists of two distinct components. The inner blood-retinal barrier is formed by the tight junctions between the endothelial cells of the retinal capillaries. And the outer side, the outer blood-retinal barrier, is formed by the retinal pigment epithelium cells, which are connected by tight junctions again. Now, this RPE, or the retinal pigment epithelium, is located between the retina and choroid, and this barrier controls the exchange of the nutrients and waste product and ions between the retina and choroid. So this is how the choroid, which is very vascular in nature, maintains a check gate with the help of this barrier with the retina, which is a very transparent structure and need to perform in a better way and to be safe from the immune function. Sometimes these various factors, for example, infections, autoimmune disorder, and the trauma can lead to the breakdown of the eye's immune privilege. And this barrier, if the middle coat of the eyeball is involved, then we call it uveitis. So broadly, such offenders can be pathogens, can infectious entities, or maybe due to some immune cells or immune response. So organisms can enter the eye through various pathways. For example, the most common associated is the bloodstream. So hematogenous mode of transport from the other side of the body or to the eye is very common. The one example is the dissemination of the fungus. It can come and can cause, as we see in endogenous endophthalmitis. And also we can see Mycobacterium tuberculosis, as you can see the retina, the chorioretinal atrophy around the blood vessels. These are actually the depicts the hematogenous spread of the bacilli from elsewhere in the body. Some organism can spread along the nerve pathways. A classic example is a herpes simplex virus, which can travel along the trigeminal nerve to affect the eye, leading to the herpetic eye disease. Also, the acute retinal necrosis is another example where the virus can spread to the other eye via the optic nerve chiasma if treatment is not started. So the viral etiologies, mainly the herpetic viruses, their primary mode of transportation into the eye is neurogenic spread. Now, sometimes infections can spread from to the eye from the nearby structure. For instance, the sinus infection, which can extend to the orbit and eye, resulting in orbital cellulitis or preseptal cellulitis. So this is how we have to understand that there are various modes of this infection. But one must remember that the inflammation is a protective response involving the immune cell, blood vessels, and the molecular mediators. And it aims to eliminate the initial cause of injury and clear out the damaged cells, tissues, and establish repair. While most infection will cause inflammation, inflammation can occur without infection also, as seen in autoimmune disease. Now, here is the spectrum. Now, while discussing the immune-mediated disorders, students should understand that the term autoimmunity or autoinflammations are often used interchangeably, but there are distinct differences between these two. Autoimmune diseases occur when the body's immune system mistakenly attacks its own tissue or organs. The immune system fails to distinguish between the foreign invaders like the bacteria, viruses, and the body's own cells, leading to self-destructive immune responses. So these diseases are primarily characterized by the presence of autoantibodies or autoantibodies that target the body's own tissue, or it is the T cells that are reactive against the self-antigens. Now, autoinflammation, on other hand, is characterized by the inappropriate activation of the innate immune system, leading to the inflammation without involvement of autoantibodies and autoreactive T cells. Now, let's see how an attack of uveitis starts. So when an antigen and inflammatory signals are detected in the eye, the antigen presenting cells in the eye, such as the dendritic cells, they capture and process this antigen and they become the activated dendritic cells. So they present this process antigens on their cell surface using the MHC molecules. Now, what happens next? That activated antigen presenting cells like the dendritic cells in the eye, they interact with the CD4 lymphocyte that possess the T cell receptor. You can see here, this is the TCR, the T cell receptors, which are capable of recognizing the type of the antigen. And with this interaction, along with the co-stimulatory signals, leads to the activation of the CD4 plus T cells. So once it is various immunosuppressive, if you see when the T cell becomes activated in response to antigen, then they starts acting. So in some of the autoimmune uveitis, various immunosuppressives acts against this activation and against the T cells. So the key difference with the steroid with immunosuppressives are that the steroids are not cytotoxic or lymphocytes. Steroids don't kill this T lymphocyte, whereas cytotoxic immunosuppressives will come and kill this T cells. So instead of doing that, what the steroid will do, the steroid will redistribute this lymphocyte, especially this T lymphocyte, from the intravascular space to the extravascular tissues like spleen, bone marrow, nodes, just telling them go back your home and rest. So this is how the entire cascade of system starts anyway. So now once 1 minute. So once activated, the CD4 T cells release the pro-inflammatory molecules called cytokines, such as the tumor necrosis factor, TNF alpha, interleukin 6, interleukin 17. So these cytokines promote the inflammation and recruit other immune cells, such as macrophages and neutrophils to the site of the inflammations. And biologicals are the drug which act against this process and specifically with this against these cytokines. So now these release cytokines and the other immune mediators attract and activate the additional immune cells, including more T lymphocyte, B lymphocyte, and inflammatory cells. So this leads to further implication of the immune response and the perpetuation of the uveitis. Now, because of this influx of the immune cells and the release of pro-inflammatory cytokines, various molecules, they start causing tissue damage in uvea and surrounding eye structure. And this damage contributes to the symptoms and complication associated with uveitis. So this is how the inflammation inside the eye starts. Now let's see. So whenever there is inflammation, the affected organ will show signs of inflammation. The 4 cardinal signs of the inflammation were described in first century Roman medical writer Celsus. So this includes redness, that is in Latin called rubor, then calor, which means the generation of the heat, and there will be a swelling of the affected organ, which was called tumor, and the pain, the dolor. And the loss of function was later added by the Rudolf Virchow. So now let's start with the rubor. So redness of the eye uveitis is very common and primarily due to ciliary congestion or circumcorneal injection or ciliary flush. So it is manifested by the ring of dilated and engorged episcleral vessels radiating from the limbus, and the anterior ciliary arteries are predominantly involved during this ciliary congestion. For the postgraduates who are watching this, you have to remember that for conjunctival congestion, it is the posterior conjunctival arteries which are involved in conjunctival congestion. So next, come to the next entity is the dolor. That means the pain. So if you see the pain in iridocyclitis or uveitis is due to ciliary spasm. The ciliary body is innervated by the trigeminal nerve, and the pain caused by the irritation of the nerve endings by the product of the inflammation. Now this pain in uveitis can be variable. Most described as a dull aching or throbbing, localize this pain, and sometimes it can be associated with referred pain, which seems to radiate over a larger area served by the trigeminal nerve. Now, because of large amount of exudation, the iris will be swollen. As a result, the pupillary reaction can become sluggish, and or abolished, and because of this swelling, the fine pattern of the iris is lost, giving rise to the appearance of the muddy iris. So that's how the swelling will occur in the affected organ, which was described as a tumor. Now, during the inflammation, because of the breach in the blood aqueous barrier, which we have discussed earlier, there occurs exudation of protein-rich fluid into the tissue space, and this can be perceived as a cells or flare in the anterior chamber. And in aqueous, these cells can be circulating due to the convection current. And if you see various kind of cells like polymorphonuclear, the predominant, and so this kind of cells you'll be seeing in the circulating in the anterior chamber. Now, what happens? Like you see in cinema hall, it's the same thing that Tyndall phenomenon will occur. The normal condition, the aqueous humor is optically empty, and if a slit lamp beam is passed through it, it cannot be seen. Now, in case of inflammation, when there is a breakdown of the blood aqueous barrier, there is increased protein content in the aqueous, and the slit beam obliquely aimed across can be clearly seen. So this is of very importance. So what we do with that, we can actually count the inflammatory cells by making a beam of 1 into 1 meter, and it is actually graded according to the Sun working group graded system. Now, coming to the flare is graded again with the scheme proposed by Sun classification. Grade 1 is the faint, which indicates the minimal flare. Grade 2 is the moderate flare, where the iris and lens details are clear. The grade 3 denotes the marked flare and the marked flare where the iris and lens details are hazy. The intense flare is the grade 4, characterized by the presence of the fibrin or plastic aqueous, making the iris and lens details very difficult to discern. So flare is often the first sign of uveitis and the last sign to disappear from the eye. It may persist despite the adequate control of the inflammation also. Now, what will happen? This will be followed by constriction of pupil. So one of the reason of this is that hyperemia and dilation of the radially arranged iris vessel, which you can see here. This is just like a bicycle spoke, the radially arranged iris vessels. So once they are dilated, they will try to constrict the pupil. Also, the chemical mediators of the inflammation, they will irritate both the iris muscles, that is the sphincter and the dilator. So there will be a tug of war between them because both will start working because of these chemical mediators. And because the sphincter takes over the dilator pupillae, so there will be a constriction of the pupil. Now, what will happen? The inflammatory cells in the anterior chamber will come across a convection current, which is primarily due to the temperature difference between a warm iris and cooler corneal surfaces. As I said, the sign of inflammation is that the affected organ will become heat. There will be generation of heat in the affected or the inflamed organ. So the iris will be warm. So as soon as the iris will come here, the warm iris, the cells will rise in front of the iris, and as soon as they will rise in front of the iris, they will come across the cooler cornea, which will make them again fall. So there will be aqueous will fall, and this is how there will be a formation of the triangular appearance. And because the entire aqueous is now full of turbid materials, the aqueous endothelial cells, they will be devoid of nutrient. And that is the reason the the corneal endothelium will desquamate at various places. And these cells, while they are going up and down due to the convection current, they will be getting attached to this corneal endothelial cells, and that's how they will give rise to the keratic precipitates. So we ophthalmologists are lucky that we can see these inflammatory cells live without performing any tissue biopsy like the rheumatologists and other subspecialties in medicine. So these keratic precipitates are composed of polymorphonuclear cells, lymphocytes, and epithelial cells. So not only that, we can actually judge the morphology of the inflammation and can categorize the inflammation into granulomatous and non-granulomatous. So KPs are normally deposited inferior half of the cornea, as I shown in my line diagram. That as a base down triangle, which is known as Earl's triangle. Now, mutton fat or the large capes can be seen in granulomatous uveitis. Fine capes are seen in herpetic eye disease and in non-granulomatous conditions. Skillet or star-shaped capes are seen in Fuchs heterochromic iridocyclitis, and old capes can be seen in various conditions, including the viral uveitis also, and they have a trinated margin. So if the inflammation is severe, then the sum of these leukocytes will try to settle down at the bottom of the anterior chamber, giving rise to the hypopyon. Now, hypopyon is a red flag signs in ophthalmology, and one should manage it aggressively. So the sluggish and literally mobile pupil, as we have discussed, because of the inflammation, what they will do, they will rest over the anterior lens capsule and may form an adhesion between them. So this kind of adhesion which forms between the iris posterior surface and the anterior surface of the lens capsule is called synechia. And if the cycloplegic starts, then very early stages, the synechia can give off in various places, giving rise to a festoon pupil. Festoon pupil. So now, when the synechia is 360 degree, then it is called annular or ring synechia. And in case of 360 degree synechia, if the crystalline lens is visible, then we call it seclusio pupillae. If we can't can't see the crystalline lens, then we call it occlusio pupillae. Now let's move to the other subset. Now, inflammation of the ciliary body can lead to the inflammation in the vitreous and formation of the snowballs. Now, if you see, the snowballs are again the aggregates of the inflammatory cells in the inferior vitreous, and these exudates are consisting of mainly the lymphocytes, macrophages, and epithelioid cells, and also the various giant cells. Now, snow banking, on the other hand, these are the severe form of inflammation in the spectrum, and they form a dense membrane which consists of collapse, vitreal, collagen, various inflammatory cells, including fibroglial cells. And this membrane can bring hyperplastic changes in the pars plana, and they can actually prevent the aqueous to secrete. So, which can sometimes lead to hypotony. So, one should aggressively manage this kind of conditions like pars plana, snow banking. Now, coming to the posterior segment, the process of the posterior segment inflammation, or as a whole, the mechanism of inflammation remains same. So only the key difference is that the retinitis and choroiditis. So I'll just try to highlight here for the benefit of the postgraduate students who are watching this program, GuruSangam. So how to differentiate between choroiditis and retinitis? One thing you remember, that the choroiditis are grayish yellow patches, where the retinitis are the white cloudy patches. And in choroiditis, you can clearly demarcate the border, whereas in retinitis, you can't. The borders are indistinct outline. But you look at this diagram, this will help you the most. So one should always remember that the retinal vessel can be seen clearly in a case of choroiditis. As you can see, this yellow patch, which is the choroiditis, and it lies beneath the blood vessel. So here you can see the blood vessels clearly. So that means it is choroiditis. Whereas in a case of retinitis, you can see here this white patch, the inflammation patch of inflammation. So retinitis is obscuring the vision, obscuring the blood vessels like here. So in retinitis, you can't see the blood vessels. So this is how you can differentiate between a choroiditis and retinitis. Now, coming to let's wrap up this lecture with the complications of the intraocular inflammation, how it happens. So we have seen that how synechia develops. So when there is a 360-degree posterior synechia, it can actually block the aqueous drainage through the trabecular meshwork, and which can lead to the bowing of the iris tissue, and it can actually give rise to the iris bombay. Now, this condition can further cause formation of the peripheral anterior synechia, and which can lead to the subsequent angle closure. So, other than this angle closure, there are several other mechanisms through which the intraocular pressure can increase in uveitis. Let's see. One is the steroid response. Steroid response is a notorious cause of glaucoma in patients with uveitis when the corticosteroid is applied for the treatment of this inflammation. So what will happen? Corticosteroid can induce myocilin within the cells of the trabecular meshwork and the canal of sclera, resulting in the increase in amount of glycosaminoglycan deposition. And also the corticosteroid inhibits the phagolytic activity of the meshwork, which clears the cells and various other debris. So net result, the combination of anti-RA, there is a rise of IOP. Also, the trabecular meshwork, as you can see in this diagram, can be blocked by the deposition of the inflammatory cells and exudate, which can actually lead to the rise of intraocular pressure. Also, like the inflammation of the trabecular meshwork or the trabeculitis in the viral infection can cause the rise of IOP. And this trabecular meshwork pores get swollen and create significant resistance to the aqueous outflow. That's why in viral uveitis, you see this trabeculitis and the IOP goes up. Now, coming to the cataract formation, which is one of the most common complication of uveitis, the cataract formation in uveitis is thought to be the result of the prolonged breakdown of the blood-aqueous barrier caused by the intraocular inflammation. The entry of the plasma phospholipids into the eye is thought to increase the lens epithelial permeability. And this increase in phospholipase A activity during the inflammation and reduction of the metabolic activity of the lens is also implicated in the etiopathogenesis of the cataract in uveitis. Also, the complication of uveitis, for example, the posterior synechia. So what will happen here? The posterior synechia can cause localized lentil oppositis, and in the anterior epithelium, which is pathologically characterized by localized area of cellular necrosis surrounding by zone of lentil opacity. So this is how the cataract will form. And also, as you know, the cataract corticosteroid also can help in lead to the cataract formation. Now, coming to the macular edema. Macular edema in uveitis is result from the disruption of the inner blood retinal barrier due to the inflammation. Intermediate uveitis and panuveitis remain the most common cause of macular edema. The disruption of the blood retinal barrier leads to the increased permeability of the retinal blood vessels. As a result, as you can see here, the fluid from the blood vessels will come and enter into the retina and can cause the macular edema. On the other hand, if you see the exudative detachment, the retinal pigment epithelium here plays a crucial role in maintaining the health of the retina, partly through the pump function. So this pump actively transports the fluid from the subretinal space to the choroid, helping keep the retina attached, like here you can see. So whenever there is a RP pump dysfunction due to inflammation, or there is a increased permeability, so a lot of fluid will enter, which results in excess accumulation of the fluid in the subretinal space. So this is further complicated by the choroidal inflammation when the amount of the fluid exceeds the capacity of the RP pump to remove it. So this balance will disrupt and there will be a exudation. So uveitic entities like Vogt-Koenige-Harada syndrome, sympathetic ophthalmia are the important causes of this retinal detachment. Now, my last part of this talk, the neovascularization, another complication, it is the process of developing the new vessels. Like what will happen, inflammation can lead to vascular changes, which again can lead to the tissue hypoxia. And in response to the tissue hypoxia and inflammation, the body releases angiogenic factors, just like vascular endothelial growth factor, VEGF. So this angiogenic factors actually activate the endothelial cells in the existing blood vessels to proliferate, and activated endothelial cells will proliferate and migrate, resulting in neovascularization. Now, this retinal neovascularization involves the proliferation of these blood vessels from the superior retina. Now, these blood vessels formed in this way are very fragile and tortuous, and they will result into hemorrhage, fibrosis, traction of the retina, and secondary glaucoma, which can impair the glaucoma vision. And another subset can happen in choroidal neovascularization, where the new vessel arising from the choroidal circulation grow through the breaks of the Brooks membrane under the RP, neurosensory retina, or combination of both. And this inflammation and factors can break down of thinning of Brooks membrane and several other factors. So that's all. So I just want to stress on the fact that to grasp the essence of a disease, one must unravel the basic mechanism. In the depth of this mechanism lies the secret of both cause and cure. I hope it will be helpful for my postgraduate students who are watching this Guru Sangam today. Thanks for your patience hearing.
Thank you, Dr. Parthapratham. You've so wonderfully expounded all the pathophysiological mechanisms of uveitis and given us such a clear understanding of, how these different signs occur. So, one question that we have is, see, apart from the active uveitis, it's also important to recognize that when uveitis is not active after you've treated a patient. So, how would you differentiate cells like vitreous cells? The vitreous cells we know persist for a pretty long time, even after resolution of the disease. So, how would you differentiate whether they are active disease or it's an inactive disease on the basis of the vitreous cells?
Yeah, I think it's a very interesting question. Sometimes the vitreous cells can be pigmented and the old vitreous cells can be there. So we need to differentiate from the old vitreous cells from the new vitreous cells. Fresh vitreous cells will be little fluffy, little larger in shape and whitish in color. And whereas the old vitreous cells, they're little smaller in size, little I'll say these are little crenated kind of margin they will have. They're the smaller, and they are not that fresh looking or whitish or yellowish in color.
Thank you. And also same for, which is a very important question asked of PGs, is how to differentiate between old and new KPs. You did cover that in your talk, but I would just like you to reiterate it again.
So the old, sometimes you have to remember that the pigmented KPs, you have to understand the macrophage actually sometimes can engulf a pigment, iris pigment, and can sit there. So we have a belief that whatever, when we tell that it's a pigmented KP, it is an old uveitis. So you have to look carefully the margin of the KPs. In a old KP, the margin will be crenated, but sometimes the fresh macrophage, one active macrophage which has engulfed one iris pigment and sitting there, it can be active. So these are this kind of pigmented KPs can be seen in sometimes viral uveitis, where the cellular anterior chamber reaction is going on and the KP is active, but it can actually give rise to a look like a old or healed keratic precipitate. So one should be careful differentiating between this kind of pigmented KPs.
Thank you. So one thing that you just mentioned was viral uveitis, and this is something that we had not been hearing about in the previous years, and now a lot of such cases because of ocular sampling and PCR studies have been done, and they turn out to be viral uveitis, especially cytomegalovirus or herpes virus. So clinically, what are the features that that can tell us that this is a viral uveitis, as opposed to
very
an idiopathic?
Yeah, very interesting question for the postgraduate. Number one where you should suspect viral uveitis if you see a iris atrophy patches. If you see a case of uveitis with iris atrophy patches. Number two, if you can see some corneal opacity with active uveitis. Number three, if you see the rise in the intraocular pressure. So these three factors, it can come isolated one with one also. So these are the indications that you are dealing with a case of viral uveitis. And one most important point is that viral uveitis, they are typically unilateral. For example, if you see the HLA B27 uveitis, it occurs in one eye, and after sometimes it will involve the other eye. Whereas the viral uveitis, it is typically one eye. The patient will come to you and will tell that I keep getting recurrence only in my right eye. And whenever I stop the steroid and steroid is tapered off, again, there is a recurrence of inflammation. It will never involve, very rarely it involves both the eyes.
Mm-hmm. And one last question, since you're here, we'll ask you about it, very commonly asked by PGs. What are the investigations you would ask of a patient where you're suspecting tubercular uveitis? So uveitis where you see these mutton fat KPs or recurrent uveitis, what are the investigations that you order?
This is very very important for the clinician also. So one thing we have to realize that we nowadays we advocate to diagnose ocular TB based on the clinical science. So we don't level a case of uveitis as a tubercular uveitis just because MON2 is positive or quantiferon gold is positive. So one need to, for the first criteria for diagnosis of tubercular uveitis, that whether it is matching the clinical phenotype of the disease. So now this clinical phenotype can be means you have to read in detail. Especially, I'll advocate the postgraduates to read the articles published by the COTS group. So number one, there's the granulomatous uveitis. There should be the retinal vasculitis with chorioretinal patches, as I showed in my talk. So once you are sure about the clinical phenotype, then you should investigate these patients for the investigation. So MON2 test, we do quantiferon gold, and we also nowadays we rely less on chest X-ray. We more we do the HRCT chest. So once these tests are positive, based on that we take a call and advocate the antitubercular treatment in these patients.
And do you also advise an abdominal CT?
Rarely on the sign. If there is this particular signs or some history, then we advocate this kind of imaging. These are all purely based on the history.
Thank you. Thank you so much. And if there are no more questions or any comments from the panelists, they're most welcome. If there are no more questions, then we'll move on to the next talk. So our next speaker is Dr. Aishwarya. Thank you, Dr. Prathapratham, first of all, for that excellent talk. And now we move on to the next speaker, Dr. Aishwarya. Dr. Aishwarya is a consultant ophthalmologist in the Department of Cataract and Refractive Surgery at the Narayan Nethralaya, Bangalore, where she also heads the Hospital Infection Control Committee. With a keen interest in complex cataract surgeries, she's passionate about the surgical training of fellows and postgraduates alike, and also has multiple publications to her credit. She will be expounding on a very important and less touched upon topic, that is hospital infection control. So we look forward to hearing you, Dr. Aishwarya. Over to you.
Thank you so much, Dr. Pinku. Today, I would like to express my gratitude towards AIOS, Dr. Harbansh Lal sir, Dr. Santosh Nawar sir, and Dr. Tinku for inviting me over here for GuruSangam. It's an opportunity, and I'm looking forward to interacting with postgraduates at this large platform. So today I would like to talk about this particular topic, which is a very varied topic. It has where it begins and where it ends. The idea is that we need to understand that we should not eventually harm the patient. And at the end of the day, it is important that infection control is everybody's business. With that thought in mind, I would like to take you towards hospital infection control. I have all my data from my own hospital in Narayan Nethralaya. So I would like to focus on the things that we have been doing, and I would like to take you through. So the hospital infection control, the aim of this particular organization, a part of this organization, is that the eye care organization should have a well-designed, comprehensive and coordinated HIC program, and it should aim at reducing and eliminating risks to patient, visitors, and provider of healthcare. In this particular execution of HIC, the hospital ideally should have an infection control committee which coordinates all infection prevention, and it should have a designated individual for infection control activities, that is an infection control officer. I would like to talk about this particular committee in detail a little bit, because depending on the size of the hospital, this committee or a team may differ. Ophthalmologists, management officers, lab directors or technicians, manager, operation theater, nursing superintendent and infection control nurse, manager of facility and manager of maintenance, and other people can constitute a part of HIC committee and also can be a part of HIC team as well. The responsibility of monitoring infection control program is vested in the HIC committee. Coming to guiding document. Now, our hospital is NABH accredited, so our guided document is the infection control manual that we utilize. And this particular manual helps us to um, institute any appropriate control measures or studies when the situation is reasonably felt to be a danger to any patient or any personnel. This particular manual is reviewed and updated on a periodic basis, and surveillance activities are carried out on a regular basis according to the manual. Now, HIC also has defined high-risk areas. We also should be able to see those in our own hospitals, and we should be able to identify the various high-risk areas, and our policy should be to implement the policies and procedures to prevent infection in these areas. Some of these areas are operation theater, the central supply area, the CSSD, the inpatient area, all areas which has inpatient beds, the outpatient areas where all areas where patient care services are provided on an outpatient basis, emergency department, the medical lab and the diagnostic areas, the biomedical waste storage areas, and the canteen or vending machines or facility management. Now, once we have identified these high-risk areas and procedures, it's important to understand that these high-risk areas, we need to have a surveillance, or the OT environment surveillance is one of them. And I would like you to take a look at that. So for OT environment surveillance, just look at these 14 points. For example, the temperature of OTs, the humidity of OTs, the medical gases, the air quality culture, the water quality culture, the surface culture, the air particle counts, the DOP testing, the pressure gradient, water analysis for chemicals, RO water, tank cleaning, raw water tank cleaning, treated water, overhead tanks and sumps, inspection for cracks and leaks, and OT staff medical examination. So these are the things which we are taking care when it comes to surveillance. The frequency will depend on the individual practice or the individual hospital. How and when would you like to do it? For example, for temperature, humidity, and medical gases, we check it regularly, daily on a regular basis. All these reports are maintained for our purpose, for regular surveillance purpose. And who does the testing? That is also very important. You need to understand there has to be a 3-step system. There should be a person who should be testing them, then another second level person who should be testing whether that test has been done and whether the validation has happened. And on top of it, there should be another person who should be overseeing these processes. Now, this control surveillance for us has been documented under infection control surveillance document. And according to this document, we do surveillance for all these high-risk areas. So just for that example, I would like to take you through to the other part of this, that in cleaning, disinfection, and sterilization practices, we need to understand that irrespective of the department or area where the equipment is being used for cleaning and sterilization practices, have to be standardized for the entire hospital. It has to be addressed at all the levels of organization, that is the ward, the OT, or the CSSD department. Now, both these areas are equally important. Sometimes we think that OT is the most important area of the hospital. No. As long as the patient is inside the hospital, no matter which area the patient is setting foot into, or where you are working, or where you are actually seeing patients, all these areas are equally important. If you look at this image in the second photograph over here, the figure of 8 is being used for doing mopping. This should be the practice everywhere when it comes to the floor mopping. Here, if you see from top to bottom, the OT is being cleaned. These are sterile OTs which have steel walls all over. And in these OTs, it is important from top to bottom, the practice has to happen. Similarly, over here, when it comes to a door, the OT door is being cleaned from top to bottom again. So this is what I would like to say, that all the levels of organizations should have similar practices everywhere. Now let's come to the cleaning standard operating procedure. Now, prior to any reprocessing to achieve disinfection or sterility, all instruments and equipment must be cleaned. If not cleaned properly, organic matter may prevent the disinfectant or sterility from having contact with the instrument and may bind and inactivate the chemical activity of the disinfectant. If an equipment is unable to be cleaned, then it is unable to be sterilized or disinfected. So we look about for manual cleaning, then we use enzymatic cleaners to clean the instrument. Then it goes to the ultrasonic cleaners and automatic washers, and it then eventually goes for packaging. Manual cleaning happens at the level of CSSD. Then we use enzymatic cleaners. After that, ultrasonic cleaners and automatic washers are used, and eventually packaging happens. I will talk about these at a later stage. Now, disinfection procedure also should have a standard operating procedure which is being followed inside the OT. Disinfection removes microorganisms without complete sterilization, and it is not a sterilizing process, and it must not be used as a convenient substitute for sterilization. And please remember that thermal disinfection is not appropriate for instruments that will be used in critical sites, as these instruments must be sterile. Disinfection can be of three types. One is high-level disinfection, intermediate disinfection, and the low-level disinfection. Now, high-level disinfection destroys all microorganisms except some bacterial spores, especially if there is heavy contamination. Intermediate disinfection inactivates Mycobacterium, tuberculosis, vegetative bacteria, most viruses and most fungi, but does not always kill bacterial spores. Low-level disinfection can kill most bacteria, some viruses and some fungi, but cannot be relied on to kill more resistant bacteria such as Mycobacterium, tuberculosis, or bacterial spores. Now, with this, there are two methods of achieving disinfection, that is thermal pasteurization or chemical disinfection. A chemical disinfection, over here, it is dependent on a number of factors including temperature, contact time, concentration, pH, presence of organic or inorganic matter, and the number and resistance of the initial bioburden on a surface. However, instrument-grade disinfectants are classified as high, intermediate, or low level, and accordingly, chemical disinfection should be taken into consideration. Now, sterilization, as we know, is the destruction of all microorganisms, can be achieved by either physical or chemical methods. Sterilization is necessary for medical devices penetrating sterile body sites. We have to remember that only the wrapped and packed sterilized material should be described as sterile. Ensure that the instrument can withstand the process, that is steam under pressure, for the process of steam sterilization. Ensure that the instrument has been adequately cleaned. Ensure that the instrument does not require any special treatment, and ensure that the records of the sterilization process and for the traceability of the instruments are kept. With this, we have been using steam under pressure, Statim 2000 and ethylene oxide. However, multiple hospitals have different protocols according to which they can utilize the protocols and write them in their SOPs. The above sterilizing methods are designed to give a sterility assurance level of at least 1 in a million as long as the process is validated and is according to the manufacturer's guidelines. Ultraviolet light units, incubators, microwave ovens, and domestic ovens must not be used for sterilizing. You can have three types of sterilizers. One is the gravity displacement type sterilizers, other is the self-contained sterilizers, or the pre-vacuum porous road sterilizers. All these sterilizers have different qualities, and they are designed for the sterilization of waste and solutions and instruments. The benchtop sterilizers are recommended for office-based practice as they're able to do small quantities of fairly simple items. And pre-vacuum or the porous road sterilizers are not suited for liquid sterilization, but are optimum for sterilization of clean instruments, gowns, drapes, linen, and other dry materials required for surgery. Moist heat sterilization examples that we are using are the autoclaves. These are the groundward gravity displacement sterilizers, which are jacketed and non-jacketed, which are designed for sterilization of waste solutions and instruments, a horizontal autoclave, a tabletop autoclave, and a cassette sterilizer. The tabletop autoclave that we are using has a short cycle and high volume pre and post vacuum pump for perfect Class B sterilization results. And in steam autoclave, which is a cassette sterilizer, it utilizes a steam process distilled water. Now, what is the minimum cycle time for steam sterilization cycles? According to the guideline for disinfection and sterilization in healthcare facilities from CDC, this is the guideline which they follow. It depends on machine to machine, eventually at the manufacturer's discretion and guidelines. But basically, a gravity displacement sterilizer, which is having wrapped instruments, textile packs, and wrapped utensils, will take an exposure time of around 30 minutes at 121 degrees centigrade. About 15 minutes for wrapped and 25 minutes for textile, and wrapped instruments will have 15 minutes. And drying time will be somewhere around 15 to 30 minutes, and 15 minutes and 15 to 30 minutes for gravity type displacement sterilizer. However, if you have a pre-vacuum type of sterilizer, you can have these items, for example, wrapped instruments, textile packs, and wrapped utensils, where the exposure time is at 132 degrees centigrade, 4 minutes, and drying time is around 20 to 30 minutes for wrapped instruments, 5 to 20 minutes for textile packs, and 20 minutes for wrapped utensils. So this is how we can actually put our guidelines into place. Ethylene oxide. Now, ethylene oxide is a very debatable topic. However, it is being used on a regular basis in multiple facilities. We have to remember one thing, that ethylene oxide is appropriate for use of sterilization for instruments and equipment made from heat labile materials or those devices that contain electronic components. They have 6 months validity after sterilization. We should know that this is carcinogenic to humans by the inhalation route of exposure. There are multiple studies which have proven them to be so. At the same time, we have to remember the gases which come out from the ethylene oxide ETO sterilization, they need to be disposed of at a level which is higher at the level from your hospital level. So that is very important. But at the same time, usage of ethylene oxide is still regularly being used, and we should probably look in a direction where ethylene oxide can be substituted by something better. Now, having said this, we know that we have a lot of instruments in our operation theater. Just have a look at this list. It basically helps me to understand what can be done where. For example, if I have a bone punch, I need to have a steam sterilization for it. If I have a caliper, it can go for steam sterilization. If I have something like a colibri process, again can go some steam sterilization. But at the end of the day, who's going to remember this? It is always probably better to put a list like this with your steam sterilizer and have a list of what all can be put over there. And if you have an ethylene oxide sterilizer, put a list over there what can be utilized. With storage and issue of items, this is also a very, very important part of our CSSD. And I would like to go towards this, that storage of instruments and equipment is an essential component in ensuring the product maintains its level of sterilization or disinfection. Most instruments and equipment are dry and packaged once they have been sterilized. They should be stored in a clean, dry environment and protected from any damage. Correct storage of sterile instruments and equipment is a critical component in keeping them sterile. With this, I would like to move towards the antibiotic policy in eye hospitals and rational use of antimicrobial agents. Antibiotic policy is a very individualistic practice for every eye hospital. The basis of this is that the microbes which have been tested in samples and the respective culture sensitivity throughout the year will form the basis of your antibiotic policy. At the same time, this policy should be documented and reviewed every year and changed as per changing trends in sensitivity in microbial cultures. Diseases are not included only to cataract, but it will have lid infections, oculoplasty infections, interventions, corneal infections, cataract surgeries, glaucoma surgeries, VIA procedures, intracameral antibiotic usage, trauma cases, prophylaxis in post-anti-VEGF injection patients, etc., etc. Dosage and frequency of the antibiotics should be mentioned, and also a compliance to antibiotic policy. If it is possible, it should be maintained. And this is a very, very crucial document for our HIC practice. Coming to laundry and linen. Now, we all know that laundry linen services are a huge topic on its own, but at the same time, if you have a written SOP, it helps you out so that the protocols are in place. We have a similar protocol like this, and these are the things that we follow, that sending linen for a wash, that the linen which is soiled with blood and body fluid should be washed separately and the stains are removed, disinfected, and then sent to the laundry for regular wash. You should have a washing machine which should have a policy written down documenting the proper usage of the washing machine, handling the clothes and their transport and the storage must be followed. Distributing the linen, how it is to be distributed to each area of the hospital by the housekeeper in charge of the linen department. There should be standing precautions. We have to remember that the strict barrier separating the infected and non-infected linen should be there. And any contaminated linen is collected in yellow polythene bags and handled the least. It should go through the process of soaked in 1% hypochlorite solution for 20 minutes and then washed in detergent, put in washing machine separately for washing and drying. We also need to think about employee safety, that the laundry personnel who are handling the dirty linen bags shall wear rubber gloves and will take appropriate precautions when handling soiled linen. Word about the washing machine, that the washing machine, spinning machine, dry machine guidelines should be in place and they should be documented and strictly adhered to. These are our checklists which we use on a regular basis when it comes to the infection control checklist. A hospital can have their own, and this is the storage area where the linen, which is the clean linen storage area, has been kept. It should be airy, it should be open, and at the same time, it should be very accessible to the people required. Coming to the kitchen sanitation and food handling issues, if you have a canteen in your hospital, then there are multiple things which have to be followed. Small things which I would like to tell over here is that the medical examination of food handlers should be done periodically and should be documented. HIC surveillance should include canteen. Your pest control activities should be regularly carried out and documented. Waste from canteen should be disposed of according to the laid down guidelines. The canteen needs valid license from FSSAI and should be updated yearly. And any outbreak needs to be evaluated for RCA, and that is the root cause analysis, and should be documented. The canteen that we have, it has been approved and verified by FSSAI, and this is the document which is provided by them. So having said this, this is also a very important part of hospital infection control, and it should not be missed. Now, coming to the appropriate engineering controls to prevent infections, we have to look at the details. That is plumbing and sewage. Now, plumbing and sewage is an area which nobody knows about most of the times because nobody goes there until unless it is basically the people who are involved in it go there. Water procurement, treatment, supply, maintenance of infrastructure, disposal of waste, cleaning of tanks, and frequency inspection and upgradation services is very, very important. And the documentation of this will give you a lot of clues for the future. AHU preventive maintenance, again, an area which is limited to very certain amount of people. Air handling unit, the cleaning, maintenance, pre-filter cleaning, fogging, AC ducts, cleaning and maintenance is very, very crucial. Replacement of the filters, whatever filters are present as HEPA filters or primary filters or pocket filters, they should have a documented replacement policy, and the frequency of validation of HEPA filters should be predetermined. Surveillance. Surveillance again is a very important part of engineering controls over here. Air surveillance, air sampler, temperature monitoring system, relative humidity, air changes, integrity of HEPA, pressure gradient across the filter bed and in the OT, particle counts and DOP testing in cases of failure of particle count test, check for seepage, maintenance log in the AHU, and the water cultures. All of these areas are crucial. They need regular checkups, and at the same time, a regular report should be given to the HIC committee or whatever internal committees that you have, so that a tight control can be put over here for the safety of patients and for the medical personnel. Just to have a look over here, this is our internal HEPA leak integrity test and the temperature and humidity record, which is done daily over here. Then coming to the air quality culture, our permissible limit is less than 35 colony forming units per meter cube per minute. And this is also something that we have for air quality culture, where the permissible limit is less than 35 CFU meter cube per minute. And what is important is that the surface culture is also done over here from, let's say, the 4 walls or random collection, the floor, the OT table, the trolley, the phaco machine, the microscope. All these are very, very important cornerstones for us. And the water culture from the scrub area, the wash area, the water storage area, the water tank flow area, which is giving us that the fact that coliform bacteria was not detected and the report has been approved. Now, coming to the housekeeping activities, irrespective of the department or the area where the equipment is, the documented policy is used for the cleaning of the entire hospital, as I mentioned earlier. The equipment cleaning includes the categorization of areas, surfaces, general cleaning procedures for surfaces, fixtures, furniture, items used in patient care. It also includes procedures for terminal cleaning, body and fluid cleanup, isolation rooms, and high-risk areas. Biomedical waste handling is an important part of housekeeping activity, and we shall discuss it in details. Now, so over here, let's come to the biomedical waste. It means any waste which is generated during the diagnosis, treatment, or immunization of human beings or animals or research activities pertaining thereto in the production or testing of biological or in health camps. What is handling? Handling means generation, sorting, segregation, collection, use of storage, packaging, loading, transportation, unloading, processing of this basically of this biomedical waste. Now, hospital waste can be compared and divided into three parts. That is biomedical waste, general waste, and other waste. Now, biomedical waste has a particular color coding in which it has to be generated and it should be disposed of. Let's come to that. So over here, we have a color coding for biomedical waste. One is the yellow, then the red, the white, the blue. This, you would see a lot of these charts which are put in all the hospitals and in all the areas which are having waste disposal bins. So over here in the yellow, you can put the PPE kits, the human tissues, the body parts, specimens, surgical waste, cotton bandages, linen dressings, and solid plaster and casts. The red one is about for using plastic material tubings, catheters, IV sets, syringes without needles, gloves, blood bags, aprons. The white is for needles, cut glass, scalpels, slides, nails, lancets, and blades. And the blue, which can be a cardboard box with blue marking, or it can be a puncture-proof box with container with a blue marking, that is for vials, glassware, contaminated glass, and ampoules. So whatever said and done, all these four types of color coding are extremely essential, universal, and they adhere to the biomedical waste guidelines from 2016, which have been improved, so on and so forth. Why we are so much concerned about biomedical waste? We have to remember that our medical, paramedical staff, the waste disposal workers, the patients, attendants, the support services, and the environment all are at risk when it comes to the biomedical waste. Now, what are the steps of waste management? The generation of waste happens at this level. Then you basically segregate them, collect them. Then the storage has to be done in a proper color-coded area, which is designated for biomedical waste. And we have to remember that it has to be transported very safely in a particularly biomedical waste collection vehicle. Now, collection packaging of biomedical waste, we have to remember that the location of containers, that is at the point of generation, will be around OT tables, injection rooms, and near nursing wards, etc. You will have to remember that the sharp containers and the waste bags should not be filled more than 3/4 capacity. And this should be collected on a daily basis at the same time. Plastic bags should not be stapled, and general waste should not be collected at the same time or in the same trolley in which the biomedical waste has been collected. Steps of collection and transferring of the biomedical waste happens like this. All the biomedical waste is put into appropriate marked bag. Do not fill the bag more than 3/4 full. Then gather and twist the top of the red bag. The twisted bag is given a single hand knot, and then you have to place this bag properly into biomedical waste container. Now let's see. If you have tied the bag like this, it is not correct because the rabbit ear fashion is not correct. You have to tie it always in a single hand knot to avoid spillage of contents from the bag. There should be a particular label for transport of biomedical waste containers like this. And over here, as per the Schedule 3 of the rules, all bags and containers carrying biomedical waste should be labeled with biohazard symbol. At the same time, the transportation has to be happening very properly, as we have discussed. It should be transported through a route which has low traffic flow of patients and visitors. Trolleys should be cleaned and disinfected thoroughly. And you have to establish a barcode and a GPS system for bags or containers containing biomedical waste to be sent out from the premises or place. Just look at these photographs. This is not correct. Waste should not be carried in open bags or through crowded areas. This is also not correct. Why? The waste should be carried in secure sealed areas, containers, bags kept in trolleys. But at the same time, if you look at the personnel over here, the personnel is not having proper PPE kits. Only mask and the cap and the gloves are there. But what about the PPE gown? Similarly, this is an overloaded trolley. Similarly, over here, there are no gloves. Over here, this covered bin is there, but there is no use of complete personal PPE equipment. So ideally, the sterilized, non-woven laminated PPE kit should be worn by the personnel who are transferring the biomedical waste. This is the vehicle that I was talking about. This vehicle has a GPS system, and segregated biomedical waste is generated from the hospital. Is required to be transported closed vehicle with proper biohazard label and contact details of the operator to the site of common biomedical waste treatment. facility, that is CBWTF, for final disposal. Now, coming to the health checkup and immunization, health checkup should be conducted for these personnel who are doing biomedical waste collection and for other medical personnel once in a year for all healthcare workers which are involved. And all healthcare workers should be immunized with hepatitis B and tetanus toxoid vaccination. Now, there should always be also a report about any accidents in spillage, which happens very often in our hospitals. That is, the incident form should be there, which should include the nature of accident, when and where it occurred, which staff was involved, what was the corrective action which was taken. We have an SOP for needle stick injuries, accidental exposure to blood and body fluids. And if the protocol is there, it is very easy for people to note on those things and not miss a single point. This is the incident reporting form, in which you can see the type of incident, what kind of fall was there, what was the type of injury, what was the severity of injury, what was the medication errors, if at all they were present. And you have to talk about anything which is like wrong time, wrong route, wrong date, wrong IV rate, omission of medication charting error. In group 2, if you have a wrong dose, wrong IV solution or extra dose, or in group 3, if there's a known allergic to medication, wrong medication and wrong patient. And these are the types of groups that you would like to actually focus upon. So this incident reporting form gives you a lot of information when it comes to these incidents, and they should be reported and documented. Talking about the surveillance activities in which we have to talk about the tracking and analyzing of infection risks, rates, and trends. Now, SSI infection rate should be calculated monthly and tracked. Data of surveillance activities should be collected monthly and consolidated into an annual report. Based on data, infection risk, rates, and trends should be generated monthly by the infection control team. Analysis includes identification causes of breakdown in the systems and processes. Corrective and preventive action taken are documented, and the data which is presented at all the monthly meetings. So this is how we should be able to take care of these surveillance activities. Hand washing, a cornerstone in infection control practices. We have been taught again and again about this, but this is one thing which is where the compliance is very, very important. Compliance is monitored monthly by each floor supervisor and verified by the administrator. The opportunities of hand washing is basically after each patient contact. Every time you've touched a patient, you have to wash your hands. Benchmark needs to be more than 80% compliance, and corrective action should be planned, and in-service training if compliance is less than 80%. Hand hygiene has 5 moments which have been regularly been trained and given to all the personnel. Before touching a patient, before a procedure, after procedure or body fluid exposure risk, after touching a patient, and last one, after touching a patient's surroundings. So these are the 5 moments which everyone needs to be aware of. PPE, we have spoken about it. We have to remember that gloves must be worn for touching any body or blood. Then masks should be worn during procedures which are likely to generate droplets of blood and other body fluids. Gowns should be worn during procedures, and they are whenever there is likely to generate splash of blood or other body fluids or any infective waste. If you need to minimize the need of emergency mouth-to-mouth resuscitation, mouthpieces and resuscitation bags and other ventilation devices should be available for use in areas in which the need for resuscitation is predictable and in the crash cart. Boots or cover shoots must be worn during procedures that are likely to generate splashes of blood and other body fluids. And cap and hair must be worn while performing any procedure, and they must be changed after contact with each patient. Where is the availability of disinfectants and soaps? So a stock register should be maintained to ensure the availability of gloves, masks, soaps, and disinfectants at the following point of use. For example, an OT, wherever the fundus fluorescein angiography is happening, where the lab process is having all the processes being done, the blood collection center, the dressing trolley, the crash cart, the glove usage and change policy should be defined in the documents, and disinfectants should be available in the biometry and application tonometry areas. We spoke about the needle stick injury before, but we have to remember that if at all there is a needle stick injury which actually happens, there is, according to a study in Georgia in CDC, exposure to HIV infection is estimated to have around 0.5% risk. And the risk in these cases of HPV infected specimen is similar, is around 5.3%. So a post-exposure prophylaxis compliant document should be available. The management should be done very properly. The immediate steps for such things should be that wash with soap and water with that area. Do not use alcohol-based antiseptic for needle stick injuries or exposure of skin. Promptly report it to the HIC team member and person should be subjected to counseling. We have to determine the status of HIV, hepatitis B, and HCV and antibodies and antigens of the patient and person exposed. Post-exposure prophylaxis treatment should be started within 2 hours based on risk assessment done, type of exposure, status of the patient by HICC chairman or infection control officer, and physician help should be sought in administering the medicines. These guidelines are very much in place. NACO, that is the government AIDS control organization, has those documents in place, and we should refer to them whenever we are forming our own guidelines. This is a particular chart that I just wanted to show that normally it is said that the eye care organization should provide adequate space for sterilization activities. And these units, for example, if you have a surgical unit, if you have a reception over there, minimum area should be around 50 square feet, and total area, which is minimum, should be around 50 square feet. And protective zone should have around 300, where you are talking about 2 rooms for recovery, 2 beds for recovery room, and 2 dress changes, and so on and so forth. Now, these are guidelines. They may or may not be feasible. At the same time, it is important to have clear distinction when it comes to the different zones. They should be separated from each other, and that is very important. And all these zones and rooms should be adequately cleaned and disinfected, which is very important. Documented procedure guidelines, they help for cleaning, packaging, disinfection, and sterilization practices, storing and issue of items. So now I'm talking about the CSSD manual, or the CSSD manual guidelines, which we have been following. I would like to give you a glimpse of it because it is a very large document. Just a glimpse of it in the sense that these are the areas that we are talking about. We are talking about the hygiene. We're talking about the personal protective equipment, how the cleaning of the department, all the instruments and sterilization activities are happening. What is it about the autoclave manuals, the operating instructions, and the indicators and definition of the terms used. With this, I would like you to take you to a small part of it, which is basically how the CSSD design is normally done. This is a design of one of our OTs. If you can see that this is the dirty zone, clean zone, and sterile zone. Let's imagine that the OT is over here. So our OT is over here. The instruments are coming out from here. The instruments go there. They go to the dirty zone. They get cleaned. And then they move towards, after cleaning, drying. Packaging is happening over here. Once the packaging is happening, our ETO machine, our autoclave sterilizers are all here. The moment the packaging is done and the instruments and the packets are dry and they have been labeled properly according to the biomarker, according to the biological indicators in place, they come out to the sterile zone. So this is what I would like to tell you about the unidirectional zone. The design of CSSD allows for unidirectional movement of various instruments from their receiving site in the dirty zone to clean zone for packing and sterilization, and then to sterile storage area. This is the red line principle, that is, whatever is dirty will be towards one side, and then the flow will be from dirty, clean to sterile. This is critical for the CSSD personnel to ensure that there is one-way flow through of instruments, and it is important to maintain functional efficiency and safety of the CSSD. No matter how the OT is designed, this protocol should be regularly followed. I would like to just take you through how the CSD functioning happens. For example, when the washing is happening over here, let's say when the segregation of the instruments have happened, the washing happens, then the inspection and assembly takes place, then the packaging takes place, then the sterilization happens, storage happens, and then the dispatch and documentation takes place. Periodic testing. Now, this is also a very important part when it comes to the quality indicators in CSSD. That is, with every batch and load, BMS simulation is done for all sterilizers. Then you have everyday test. Every day we have a leak test and a Bovidic test for the steam sterilizer on an empty load. Once a week, we do a biological indicator to check the efficiency of steam sterilizers, plasma, and EO, which is the report received in 48 hours. Every day, foil test for checking the efficiency of ultrasonic cleaner is done on empty load. And once a year, calibration and validation of the machines is done. At the same time, when it comes to the quality indicators in CSSD, let's see how it goes. So if you have a packing indicator over here, the pre-sterilization, this blue line gets converted into a black line over here, which basically means that everything is okay. Packing indicator with ethylene oxide, from this blue line, the color changes happen. Okay. The packing indicator for hydrogen peroxide, if you have a plasma sterilizer, then from this line, the color changes happen over here to a lighter, this one, to a lighter color. The Bovidic test from the steam, from yellow, it goes to a darker black color. Batch monitoring strip, which is used, goes from a yellow to a dark black color. And MVI steam indicator from pink over here, it goes to dark color over here. This change of the color of indicator strip post sterilization indicates successful sterilization. Now coming to the routine sterilization loads. In linen nodes, we have to remember that physical parameter monitoring of every sterilization cycle is important. You can have an external and internal class 1 chemical indicator for this, and monitoring of any one is okay, like a BI or a BI with class 5 indicator, or a class 5 indicator alone, or a class 6 PCD can be done. When you have surgical instruments or implants, then the physical parameter monitoring of every sterilization cycle is of course important. Then the external and internal class 1 chemical indicator can be used, but monitoring of every load with BI with class 5 indicator or a Bovidic when load has porous instruments should be done. Now, this is the BDS monitoring register. As you can see, these are operational checks. BDS test and leak test are done daily at the start of the day. This is the sterilizer validation biological indicators, which we do once a week, and batch monitoring and PCD, which is done. This is the sterilization process records, which are duly maintained. Now, you would see that in CSSD, you saw a lot of documents. Yes, the CSSD has a lot of documents because you need to have a CSSD receipt register, an issue register, a record for autoclave sterilization effectiveness, the number of loads, the personal responsible, equipment breakdowns, etc. Then you need to have a EO sterilization if you are using, then the autoclave receipts, monitoring details of the cycle and program, etc. Then you need a record for the re-sterilization for autoclave and EO, a checklist that is autoclave operation, a lab report, a register where you can have all the autoclave plasma and EO effectiveness, and manuals, which are for the instructions, of course. Now coming to a very important crucial part, which is known as recall. What is recall? Recall is basically that if there is any product or suspected of being substandard, which is identified, quarantined, collected, investigated, and the findings are recorded. We have to set a guideline on the recall of sterilized items if the sterilization process were found to be later deficient or failed. And recall policy is described as a series of activities initiated to enable rapid recall of all items suspected to be non-sterile. As per recall policy, set indicators should be documented, load indicators should be documented, batch numbers of fluids used should be documented, implant details should be documented, and staff trained and recall procedures should be documented. This is how the documentation should be done when it comes to the batch numbers, the load indicators, the set indicators, and these are the implant records. Procedure for recall. There are documented processes like this. You have to outline the circumstances for issuing a recall, designation of department and staff responsible for executing a recall, send a recall notice, identify the persons or department for which the notice is intended. If there is a failed BI, items from that test plus previous loads after the last known good test must be immediately recalled. Label the sterilizer as out of service. Include the recall document to record products and quality of products to be returned in recall. Includes the action to be taken by persons receiving notice, that is return or hold for collection by CSSD staff, and assessment of patient risk. I would like you to show a particular video, which is for recall procedure training purposes that we use in our hospital. Okay, it seems that it is getting slow. I'll just see if I can play it from elsewhere. Okay, now coming to the next one, which is the reprocessor for instruments, the equipment and devices. Now what happens is that we use single medical use devices, and the supply of this is parallel by another trend, which is attempting to clean and reuse these single use devices and medical supplies. These devices are often complex in design, and cleaning efforts by hospitals or third-party processors may be inadequate. Eye hospitals should have a strict documented policy considering the reuse of single-use medical devices, and they should have detailed procedures and follow-ups. Now, appropriate level of reprocessing should be done. Servicing of instrument and equipment should be done. And the staff who work in sterilizing service department should be responsible for reprocessing of instruments and equipment, must have undergone formal training in how to clean and disinfect and sterilize instruments and equipment. The level of training must be appropriate for the level of responsibility that the staff member is expected to undertake. Selected items that require special reprocessing are, for example, phaco and vitrectomy probes and tubings, the respiratory and anesthetic apparatus, and manufacturer's instructions must be followed. Patient care equipment, that is any equipment that is used for patient and touches only the intact skin, such as bedpans, etc., should be cleaned or disinfected in hot water. And single-use devices which are low risk when are used for the first time and remain low risk after reprocessing, provided cleaning and sterilization or disinfection of the single-use device is conducted in an appropriate manner. So we have protocols for this also, how you will do the special medical devices. For example, a phaco handpiece, how it should be done. For example, in the operating room, you will remove the irrigation aspiration tubing from the handpiece, you will unplug the handpiece. Then in CSSD, you will go to the remove the chamber sleeve and tip using a tip wrench and discard according to surgical facility guidelines. You will wipe off any residue from the handpiece with soft, clean, lint-free, non-abrasive cloth. Use a syringe to push a minimum of 120 cc at room temperature sterile deionized water. Use the same syringe, flush both the ports with minimum 60 cc of air, so on and so forth. So basically what I want to say is that the protocols for these reusable special medical devices should be very much in place. Now, SSIs, we have spoken about it. I would like to talk about now the SSI endophthalmitis register, which should be maintained. All these cases should be noted and noted down and documented. Monthly and yearly SSI rate should be calculated and discussed in internal HIC meetings, and a complete investigation should be done. This is a root cause analysis of what we would like to go for. For example, the microbiological surveillance in a case like that, whether it was adequate or not, all the OT sterilization protocols, whether they were followed or not, whether the consumables were okay or not when it comes to the consumables used during the surgery. Were any surgeons or staff factors responsible for the infection? Were any patient factors responsible for the infection? Or how was the lab investigations which were undertaken after the infection came into light? So this is also something that we do over here. This is a particular safety practice that we are using. That is, anything which are using intracamerally consumables, we are doing the cultures of them by ourselves as well. For example, if there is a proparacaine eye drops, we do and see the culture report of these also by ourselves to make sure that whatever we are putting in the patient's eye is actually not having any microorganisms. For example, the solutions which we are using or the T plus drops that we are using, everything is taken care of as well for the cultures. Every batch is tested, and then only that batch is allowed to be utilized in the hospital. Now, there is something which is known as Emergency Operation Theatre Microbiological Surveillance Protocol. Normal protocols are, of course, all in place, but what if there is an emergency in which emergency cultures have to be done? For example, in emergency cultures, we do it for aerobic organisms. Anaerobic and fungal cultures are to be taken if it is indicated by the situation. They are taken from specific theater in the following situations. Isolation of organism and samples from post-operative infections and endophthalmitis cases operated in that OT. Known infected or culture positive cases are planned for surgery in the OT. If there was maintenance work which was performed and is likely to have caused contamination, or there is leakage or seepage of water or fluid into the theater. So up to 50 colony forming units per ml is permissible for continuation of theater functioning reference. Critical CFUs are defined as CFUs values above 50 CFU. This is a critical report, and so critical report standard with readback should be followed. On the receipt of the report, all cases scheduled for the theater are either transferred to another theater or postponed. The cultures would be specific for each theater within the complex. The OT is reopened after one set of cultures from surfaces, air and water are negative. And in case of OT being shut down for civil work and maintenance, the OT is opened after 3 set of serial cultures on consecutive days are negative. Now, this is a protocol that we have been following. Of course, every hospital will have their own. Last part of my talk is about the induction training when it comes to patients, when it comes to medical personnel who are joining the hospitals. Pre-induction training is given to all categories of staff. It is important that the employees who are identified as occupationally exposed or potentially occupationally exposed to blood or potentially infectious materials will receive training, which includes the following. That is about the HICC standards, the epidemiology of the diseases, the explanation of the hospital exposure control plan, the information on the type and proper uses of PPEs, the information on hepatitis B, and what to do and what not, whom to call in emergency, an explanation of the procedure to follow if the employee has exposure and how they should report the accident and medical care that they can be expected to give. The pre-induction training is a part that HR takes part in, and the new employees of the hospital with patient care responsibilities or contact with patient specimens or equipment shall receive an orientation class in infection control. You can have a training schedule, a post-training assessment, an acceptable benchmark should be taken into consideration, and retraining and reassessment for those who are not meeting the benchmark till they achieve it. So you can have things like hand wash and use of gloves and disinfectants, whether the OPD dressing, the OT staff, whether the etiquette is proper or not, the A scan and B scan FFA areas, how the benchmarks have been set. Trainings have to be done regularly. Relevant periodic training should be done. Hand washing training, biomedical waste disposal training, needle stick injury training, CPR training, all form a part of HIC training. So having said this, I would like to tell you that HIC is not just something that starts from the top of the organization. Of course, it starts from there. The initiative comes from there. This is my HIC team, which comprises of right now some very, very important clinicians and management personnel over here. But this is the ground force which works for HIC on a regular 24/7 basis. And this is the team in OT who does everything meticulously to ensure that each and every eye is taken care of. Thank you so much. I would like to express my gratitude to some of my members of my team, Dr. Ishita, Mrs. Umangla, Dr. Sanket Bhatnagar, Dr. Sneha, Dr. Bindu, Dr. Ram Gopal, Dr. Padma Malni, Group Captain Mr. S.K. Mittal, HIC team and committee, Dr. Naren Shetty sir, and Dr. Rohit Shetty sir for this wonderful organization that we have built up. And thanks to Dr. Bhujan Shetty sir, who envisioned this whole process and started us and gave us this platform. Thanks a lot. Thank you, AIOS.
Thank you, Dr. Aishwarya, for that very, very detailed and insightful talk on the control of hospital infections. As they say, a system is only as strong as its weakest link. And your talk has emphasized the facts that the principles of infection control have to be followed even at the smallest of situation or the smallest of step, because that could be the weakest link that can cause the infection. So you very nicely highlighted all these things. Just a few questions that we have from our audience. So one question is that what is your protocol on managing cluster endophthalmitis? How do you define it, and what is the protocol? Very quickly, if you could tell us.
So for cluster endophthalmitis, our protocols are in place. Like I said, that we have infection control. We have a form which the patients have to be filled in. All the protocols are followed. A particular register is maintained for all the documented processes. We go back, like explained in the root cause analysis, the fishbone diagram over there. All the processes are looked into, and immediately once the process is identified or the cause is identified, the organization is informed about it and rectification and measures are taken. Till now, for the past 10, 11 years that I have been in the hospital, thankfully, we've not had a cluster endophthalmitis till now. So as of now, the ideal process is once the endophthalmitis patients have been identified, the suitable bodies in the government have to be notified, whichever state you are in. You may be having different protocols in different states. And once that is done, then a root cause analysis is taken by other hospitals for to ensure that the processes are in place for the infection control practices. And yes, it is important to look at each and every cornerstone of endophthalmitis, if at all, if there is any. We recently had, I think last year, there was a lot of outbreak of TAS that we had, and I also presented on AIOS platform about TAS, about one case which was there, but again, the patient had recovered. But at the same time, the root cause analysis for even TAS should be similar to how you would do for an endophthalmitis case. No cornerstone should be, not looked into. You should look at all the parameters.
Very rightly said. The second question is on the sterilization of equipment in the OPD. So how would you recommend that we sterilize gonioscopy lenses, laser lenses, tonometry prisms? What is your protocol for sterilizing these instruments in the OPD?
Yes. So ideally, it is said that there are certain manufacturer guidelines which have been put. Nowadays, earlier we used to use only one company lenses. Other companies have also come in. Soap and water initially for gonio lenses is recommended initially, but wiping it off, drying it, and then utilizing it. In some hospitals, it is said that they use alcohol swipes also, only for cleaning purpose, which is actually not, but then you have to wait for it to dry. That is also important. So there are different protocols. The main thing is that you should not be scratching those lenses, which is very important. When you use alcohol swipes, it is said that you make a lot of scratches. So soap and water is something that they would like to do, but dry it and then utilize it.
Yeah, I think so. In between patients, the instruments should be cleaned with soap and water. I think that is a very important point because many times I've seen postgraduate or residents reusing it, even washing it with just plain water. But soap is an important, and it's known to be bactericidal and virucidal. So the other question is, when you have ETO'd equipment or when you have autoclaved instruments in the OT, how long do you keep them for before you send them for? So how long does autoclaving work and how long does ETO?
So autoclave is for 3 days. That after that we always go for re-sterilization of the instruments. And for ETO, it can be kept for 6 months, and also depends on the manufacturer's guidelines also. But it can be ideally kept for 6 months. That is what the recommended practices are.
And my last question to you is, what are the protocols whenever you have a patient with HIV or it's a hepatitis patient? So what are the OT protocols that you follow?
So
both pre-operatively, intra and post-operative.
So one thing that we are regularly doing is that all our patients with consent undergo HIV, HPS-AG and HCV testing for any invasive procedure. That is number one. Second thing is that moment we find out that the patient is a biohazard case, the patient will always be taken into the OT as the last case. If there are multiple cases of such sort, then always HPS-AG patients will get more prominence and then HIV will be operated last. Third thing is that proper PPE kit, that is cap, mask, double gloves, PPE kit, and gloves along with the foot covers will be provided to the doctor who's operating. There will be yellow bags which will be kept inside the OT for proper disposal. The contaminated linen, as I discussed in my presentation, will be disposed of in a particular manner by utilizing 1% hypochlorite solution, dipping it in for 20 minutes, and then only taking it for washing. We have a separate washing machine for all biohazard cases. We do not mix it with normal routine cases. So I think these are the few points that I would like to emphasize right now.
Okay. And any special precautions while cleaning the OT after you've done such a patient?
Yes.
Anything
So,
special?
like I said, since it is the last case, after that, the thorough current cleaning protocol will take place. And also, if it is in between, sometimes there's an emergency, and we have cases after that also, then fogging probably has to be done in those cases. So fogging will ensure that your OT is sterile for next usage.
Thank you so much. That was
Thank
an
you.
excellent exposition on the control of hospital infections. Thank you so much. Our next speaker is Dr. Kalai Vani, but I was told that she was having some problems in connectivity at her end. So I don't think that she's been. Dr. Kalai Vani, are you there?
Yes, madam, I'm here.
Oh, good to see you.
Yes, madam.
So very nice to see you here. Finally, you did manage to join in.
Yes, madam.
Oh. So, Dr. Kalai Vani is a professor at the Vinayaka Missions Medical College, Karaikal. Not only is she a respected teacher, but she's also been an examiner at various universities. She's organized many CMEs and presented at multiple fora and published extensively. So, Dr. Kalaivani, over to you. She'll be talking to us on masquerade syndrome in uveitis. Over to you, Dr. Kalaivani.
Yes, madam. Yes, madam. Able to see my screen, madam?
No, we cannot see your screen. No. Yes. So now you make it full screen at the bottom.
Yes, madam.
Yeah. It's not.
Yes.
Yes. Fine. Yes.
Yes, madam.
Please continue.
Yes, madam. First of all, thanks for giving me the opportunity in AIOS. My topic for today's discussion is uveitis masquerade syndrome. Actually, uveitis masquerade is a simulation of an ocular inflammatory condition by a neoplastic or non-neoplastic disease. It is also called as a pseudo-uveitis. The name masquerade syndrome was first coined by Theodore in 1967 for a case of conjunctival carcinoma presented as chronic conjunctivitis. According to Martin's dictionary, the word mask generates the verb masquerade, meaning to appear in disguise, and the noun masquerade pronounced as masquerade, meaning false show. There are few neoplastic and non-neoplastic conditions presenting as uveitis masquerade. The neoplastic conditions are primary intraocular lymphomas, primary choroidal lymphoma, uveal melanoma, retinoblastoma, ocular reticulum cell sarcoma, ocular metastasis from the lungs and breast, and the leukemia. And non-neoplastic conditions presenting as masquerade include retained intraocular foreign body, anterior persistent hyperplastic vitreous, juvenile xanthogranuloma of iris, neurofibroma of iris, amyloidosis, rhegmatogenous retinal detachment and retinoschisis, some cases of retinitis pigmentosa and ocular ischemic syndrome. First, we will see one by one primary vitreoretinal lymphoma. This is a non-Hodgkin's diffuse B-cell lymphoma presenting usually in the 5th and 6th decade of life. It's a high-grade neoplasia with a non-aggressive course, and 90% of the patients are present with the central retinal system involvement. And 75% of the patients with the intraocular lymphoma will present with the bilateral steroid-resistant uveitis. And the anterior chamber involvement will be 30%. Common symptoms will be the floaters and blurred vision. 20% of the primary vitreoretinal lymphoma patients may have the RPE, retinal pigment epithelial infiltrates, as shown in this figure as a yellowish infiltrate in the sub-RPE level, and some may present with the steroid-resistant vitritis and hemorrhagic retinal vasculitis. Patients may present with the Gunn syndrome, that is G stands for glaucoma and U for uveitis, with the neurological signs, may be a coexistence. And treatment include steroids and radiotherapy for the tumor. Chemotherapy is reserved only for the recurrent cases, and 5-year survival rate is 3 to 4% only. Now coming to the second topic, that is primary choroidal lymphoma. They present as a multifocal creamy white to yellow choroidal infiltrates. More than 70% of the uveal lymphomas exhibit extrascleral extension. In B scan, we can see a low reflectivity mass near the optic nerve head. That is the classical site for taking the biopsy. Now, endocyanine green angiography reveals the characteristic focal regions of hypofluorescence corresponding to the clinically observed choroidal infiltrate. In enhanced depth imaging OCT, the choroidal surface appears to be smooth when the lymphoma infiltration is thin. It appears rippled when it is medium infiltration and undulating when there is a thick infiltration. So primary choroidal and iridal lymphomas relatively carry a good prognosis. Then choroidal granulomas, they are commonly associated with tuberculosis and sarcoidosis, rarely associated with syphilis and toxocara. They appear as a yellowish white subretinal mass that is present in the choroid. These arrows shows the extension of the mass with the retinal vessels growing over the tumor. There may be associated subretinal fluid with exudative retinal detachment, and OCT shows a choroidal thickening with RPE disruption. Challenging cases may need a fine needle aspiration biopsy. Then coming to the next topic, uveal melanoma, sometimes masquerade as uveitis. Uveal melanoma is the commonest neoplasm of the eye occurring in the 6th decade of life. The choroid posterior to the equator is the common site involved. It may appear as a gray or brown color mass with the overlying retinal vessels. Sometimes amelanotic tumors also may be there that they may have a yellow color appearance. Usually these tumors present with the unilateral chronic uveitis and not responding to conventional medical therapy. Ciliary body melanoma contributes to 10% of the uveal melanoma as is shown in this picture. It can present with the sentinel vessel overlying, that is sentinel vessel point to the tumor. It will be present over the area of the mass which is present. It can present with the unilateral pan uveitis and raised intraocular pressure. Then coming to the next neoplastic condition masquerading as uveitis is retinoblastoma. This is the commonest pediatric intraocular malignancy and one of the most feared uveitis masquerade. Misdiagnosis often lead on to death. Inflammation usually occurs from the tumor necrosis, and more commonly the tumor cells are mistaken for inflammatory cells and may get a pseudohypopion also. So these are the presentation of retinoblastoma patient with the leukocoria, and second picture, that is B, shows the endophytic growth of retinoblastoma, and the C picture shows the pseudohypopion with the tumor cells, and the D picture shows the orbital infiltration, that is this patient has orbital cellulitis and pain with the thicical eye. Then coming to the next topic, metastatic carcinoma can also mimic as uveitis. The primary tumors arising from the lung and the breast can cause bilateral choroidal involvement with the multiple gray-yellow lesions. Iris and ciliary body can also be involved, presenting as anterior uveitis. Metastatic carcinoma can be associated with vitritis, exudative retinal detachment, and sometimes with the optic disc involvement, papilledema. Horton et al. In American Journal of Respiratory and Critical Care Medicine reported a case of adenocarcinoma right lung in a 73-year-old male presenting with the bilateral uveitis. Leukemia. Ocular manifestations can occur in 75% of the leukemia patients. They present with the iritis, nodular or diffuse thickening of the iris, and pseudohypopion. Leukemic patients in the posterior segment, they will have the rod spots or the white-centered hemorrhages, cotton wool spots, peripheral neovascularization due to the hyperviscosity of blood, maybe the other manifestations, and there can be exudative retinal detachment due to choroidal infiltration and consequent ischemia. Then the last malignant condition mimicking as uveitis is ocular reticulum cell sarcoma. Approximately 5 out of 7 cases present with the uveitis. It is a tumor infiltrate of the retina with the associated retinochoroiditis causing clouding of the vitreous, exudative retinal detachment, and glaucoma. Vitreous aspiration helps to confirm the diagnosis, and this reticulum cell carcinoma, that is the eye involvement, may accompany or precede the brain involvement. They are usually radiosensitive tumor. So coming to the benign masquerade syndromes, first one is the ocular ischemic syndrome. Nearly 20% of the ocular ischemic syndrome patients may have the inflammatory cells in the anterior chamber, which are rarely more than grade 2 and may present with the occasional keratic precipitates on the back of cornea with the posterior synechiae also. And these patients usually present with the conjunctival congestion, chemosis, massive corneal edema, iridocyclitis picture, and neovascularization on the iris and neovascular glaucoma. These are the usual anterior segment manifestations. Then the intraocular foreign body can also mimic as uveitis. The reaction around the foreign body can simulate the pars planitis if it is the posterior segment of foreign body. A copper foreign body can cause acute intensive anterior uveitis. This is a picture showing the retro illumination. There is a golden yellow fibrillary membrane present in the anterior vitreous face in a copper foreign body. Then iron foreign body can cause siderosis. Siderosis may be associated with the chronic anterior or intermediate uveitis. It may present as intermediate uveitis or chronic anterior uveitis. The typical picture of siderosis is a rust spot as given in this picture, which may be seen over the iris surface or sometimes beneath the anterior lens capsule. Then anterior persistent hyperplastic primary vitreous. It can usually present with the microphthalmus, dilated iris vessels, elongated ciliary processes, abundant fibrovascular membrane may be seen around the lens. It is usually confused with the chronic iritis and complicated cataract. Juvenile xanthogranuloma of iris is a yellow, poorly demarcated iris tumor present with the spontaneous hyphema simulating an iridocyclitis. It's common in the first year of life. It can occur in the adults also. Iridectomy and iridocyclectomy are the treatment options. Then coming to the next one, that is neurofibroma of the iris. It may be congenital or it may develop during puberty, pregnancy, or after trauma. So usually it may present as a leash nodule, maybe of mushroom type or the flat. This may be mistaken for the Bushaka's nodule present in the granulomatous iridocyclitis. Then comes the glaucoma capsulaire. It is the pseudo-exfoliation of the lens capsule. It may present as a bluish white or gray flux, usually float in the aqueous, and they may be mistaken as the aqueous cells and diagnosed as uveitis. But the classical three-zone picture present over the lens surface that will help to diagnose, differentiate the iritis from glaucoma capsulaire. You'll be able to see a central translucent zone and a narrow, clear intermediate zone with the peripheral wheel-like membrane that helps to differentiate. Now the next comes the amyloidosis. Anterior vitreous is filled with the cells, although the cells are larger than the inflammatory cells. The vitreous opacities may be cellular, membranous, or wheel-like pattern. The diagnosis of amyloid is confirmed by biopsy. Apart from the masquerading as uveitis, amyloid patients may have the lattice corneal, the stromal dystrophy, or may have the cataract, glaucoma, and other anterior segment manifestations. Then retinitis pigmentosa patients can also mimic as iritis patients. Datta and Mania Roy et al. In their study quoted that 22 patients out of 8,364 retinitis pigmentosa patients present with the intermediate or posterior uveitis. They present with the vitreous cells and cystoid macular edema as a result of photoreceptor death. So these remnants will be seen as vitreous cells. They may be misdiagnosed as posterior uveitis. Then rhegmatogenous RD can sometimes present with the anterior uveitis with the cells and flare, and sometimes with the posterior synechiae also. And Schwartz syndrome, which is rhegmatogenous retinal detachment with a high intraocular pressure, can mimic as hypertensive anterior uveitis. Then fundus flavimaculatus. This is an yellow abnormal accumulation of lipofuscin-like substance at the level of retinal pigment epithelium. Because the retinal pigment epithelium lost its phagocytic function, it is unable to digest the photoreceptor outer segment. So they get accumulated and may be confused with the disseminated choroiditis. Now, some of the intraocular as well as systemic medications also can present with the uveitis. Triamcinolone acetate is a common drug which can migrate anteriorly and produce a pseudohypopyon. It can lead on to sterile endophthalmitis also. Similarly, anti-VEGF after 1 or 2 injections can cause transient anterior uveitis, but the incidence is very low. That is 0.026 per 1000 injections. Then some of the systemic medications also cause uveitis, that is ribavirin, which is a anti-HIV drug, which is known to cause severe intraocular inflammation, which is dose dependent and reversible. Once you stop the drug, the uveitis component will be resolving. The non-granulomatous iridocyclitis is a common presentation. It usually carries a good prognosis. So the picture shows the rifabutin induced iridocyclitis. On the take-home message is, masquerade syndrome represents the uncommon presentation of rare diseases. So clinical suspicion is an important step to diagnose neoplastic masquerade syndrome. A rule of thumb described by Dr. Whitcup gives a clue about the unresponsiveness of these patients to routine anti-inflammatory drugs. Early diagnosis of malignancy masquerading as uveitis is crucial, both for restoring the vision as well as to restore to life-saving also. So it can be achieved by thorough history, careful ophthalmic and systemic evaluation, aided by ancillary testing. So these are some of the references, and thank you for the opportunity given.
Thank you, Dr. Kalaivani. You can stop sharing your screen now. Yeah.
Yes, madam.
Oh, yeah. Thank you for that very nice and detailed talks and for the excellent pictures that you showed detailing all the masquerade syndromes in uveitis. So
Yes.
congratulations to you. So like you mentioned, masquerade syndromes could be neoplastic or non-neoplastic.
Yes, madam.
So among the neoplastic conditions, like you said, the primary intraocular lymphoma is one of common masquerade conditions that is often misdiagnosed and missed. So what is, you said like a high index of suspicion should be kept. So what are the features that would make us suspect when we see a lot of vitritis or vitreous cells in a patient? How would you suspect that this patient has a primary intraocular lymphoma and not uveitis?
Actually, these masquerade patients will be elderly patients. They present with the unilateral uveitis or vitritis. They will not be responding to routine steroid management, madam. So any chronic iridocyclitic patients not responding to uveitis, we have to work up for other anterior and posterior segment causes. So detailed evaluation like a routine biopsy, they told with the B scan, so if they see a mass close to the optic nerve head and take a biopsy to rule out intraocular lymphomas.
Actually, some of these patients may even respond to steroid initially, and then they would have a recurrence.
Yes,
so in any such, and also because steroids are very lympholytic, they would destroy the lymphoma cells. So whenever you have a suspicion, you have to stop the steroids, wait for at least 2 months, and then take a vitreous biopsy.
Definitely, madam.
So the stopping of the steroids is very important if you want to take a sample and do a biopsy.
And indocyanine green angiography also helps to pick up the lesions.
If you have those subretinal lesions, then also again you can have
Yes, madam. And enhanced depth OCT also facilitates early diagnosis.
Okay. And the other point that you've highlighted is that in any uveitis case, it's very important to do a thorough dilated fundus examination.
Yes, madam.
So never label a patient as just anterior uveitis and start giving him steroid drops. There could be so many other conditions lurking in the background. So a dilated fundus examination is imperative in any patient of uveitis. And you've shown all these conditions that can occur. Also, another condition that very commonly mimics uveitis is CSR with fibrin. So, it gives the appearance of choroiditis, and then the patient is started on steroids, which again aggravates the condition.
Yes, ma'am.
So, I think that is another condition that we should be wary of.
Amelanotic uveal melanoma, choroidal melanoma, routine their indirect ophthalmoscopic examination. If it is pigmented, it is easy to pick up, madam. Amelanotic, sometimes we may miss it. And that may present as a chronic iridocyclitis. So thorough workup is important.
Mm. Right. Also, the foreign bodies that you mentioned, again, there may be sometimes which I've myself experienced this. There was a small foreign body at the angle, and the patient had kept on having a cycle of recurrent inflammation. It's only when we did gonioscopy that we could identify the foreign body.
Yes,
So
ma'am.
these little things we have to keep in our mind. So overall, a very excellent talk, and thank you for the amazing.
Sorry for the delay in joining, madam. I tried a lot.
No,
And
you
finally
came
I
at the
could get
perfect
connected.
time, you joined in at the perfect time. There was no problem at all. So
My
I think
sincere thanks, madam, for giving me the opportunity. First time I'm presenting in AIOS.
oh, congratulations.
Yes,
Excellent.
ma'am.
So with that, we've come to yet another session of Guru Sangam. And I'm sure it's been a very informative, a very illuminating session for all the attendees. We would be having our third episode on next Sunday. So do log in, and there'll be another four new talks for you. Again, by a very stellar panel of speakers. So my thanks to all the speakers today. They've done an excellent job. And the video will be there on the AIOS YouTube channel. So anyone who has missed or anyone who wants to again go back and do so, these videos will be there. And I thank you once again. I also thank the President, Dr. Harbans Lal, Dr. Santosh Honavar, the Secretary of AIOS, for this very well-crafted Guru Sangam series. And with that, I bid you a good night and look forward to having all the attendees and more PG students next Sunday. Thank you so much.